Again, thank you very much, Julia. Thank you very much, Lenny, for your presentation, and Michelle for your introduction. And well, as you know, as Michelle already said, and everyone, my name is Jennifer Cohen. I am a master's student at McGill under the supervision of Dr. Michel Perrault. And I'm here to talk about the part of that larger project from our lab, which is whose aim is to better adapt services for people who use opioids, which is the bigger project. And as we know, people living with chronic pain are frequently prescribed opioid medications to manage their pain. And this is how this population became the focus of my master's project, which aims to better adapt mental health services to the needs of people living with chronic pain. And to accomplish this aim, we set out to investigate the perceived needs for mental health care of people living with chronic pain. Now, let me give you first some context into why we are talking about mental health care in the context of chronic pain. And Danny hinted a little bit about that I was going to be talking about mental health in the context of chronic pain. Now, we know from the literature that mental health problems are very frequent in the chronic pain population, such that up to 50% may suffer from depression. Approximately 30% may suffer from anxiety. And there's been a very well-studied bidirectional relationship between chronic pain and mental health, whether mental health problems precede chronic pain or chronic pain precedes the incident of the presentation of mental health problems. There's also a wide range of psychological factors, including negative emotions and beliefs, that are known to play an important role in the development and maintenance of chronic pain. So that's where we include them in mental health, in the mental health context, right? There's also a fair amount of data indicating that long-term therapy can lead, long-term opioid therapy, pharmacological therapy, specifically opioid therapy, can lead to the development of mental health problems, including major depression. And in a minority of chronic pain patients maintain an opioid therapy, the use of opioids can also lead to fatal or non-fatal overdoses. Then, taking all this into consideration, clinical guidelines for the management of chronic non-cancer pain have recommended non-pharmacological therapy to be considered as a first line of treatment. And non-pharmacological therapy can include a wide range of options in which mental health services can be included. And mental health services, we can think of them, for example, as consultations with mental health providers delivering psychological interventions. And there are a number of psychological interventions that have shown to be effective at improving pain outcomes and mental health outcomes, such as cognitive behavioral therapy for chronic pain, mindfulness-based stress reduction, acceptance and commitment therapy, brief interventions, and others. But even despite this importance, well, we know that access to mental health services is generally considered to be very problematic. Factors such as costs, insurance, stigma, service availability, and many other more are frequently reported as obstacles to access mental health services. Now, because of the relevance and the importance of mental health services in the context of chronic pain, then we decided to carry out this study within that larger project, whose objective was to document in a sample of people living with chronic pain their perceived needs for mental health care. Now, mental health care in my presentation will be a synonym of mental health services. And we decided to document, the objective was to document their perceived needs for mental health care, their obstacles to obtain mental health care, and their suggestions on what could help them with their problems or conditions. And well, how did we carry this out? This project started at the beginning of 2020, and as you know, may remember or may not, that's when the pandemic started, and we had to change things a little bit. And we decided to take the opportunity to launch an online survey, including quantitative and qualitative data collection methods, and to have that complementarity as well, and to take it well, and to, of course, be able to start our project. So we carried out a survey that intended to document the perceived needs in terms of mental health care of people living with chronic pain and co-occurring mental health problems. When we were designing this, we received feedback from the project's advisory committee, from my master's project committee as well. We received feedback and piloted it with patient partners from the Quebec Chronic Pain Association, who would later on distribute the survey to their members. It was then programmed onto the platform Lime Survey, which is hosted at McGill University. And at the end, we ended up recruiting 140 participants through the Quebec Chronic Pain Association and through social media channels. For this first part of the project, and then for this presentation as well, we will be talking about the first, of course, the quantitative analysis that we carried out on the first part of the analysis stages, and a qualitative analysis of a question. Well, for the quantitative analysis, we analyzed the close-ended questions that collected descriptive statistics of participants that declared having a mental health problem, their perceived needs for care, for mental health care, psychological distress levels, and perceived support levels. Now, for the perceived need for mental health care, we used the perceived need for care questionnaire. I'm going to go over that to explain a little bit how that measure was constructed, and that was included within the close-ended questions, which means our quantitative analysis. So in this measure, participants are asked what help they have received in the past 12 months for their mental health problem, in our case, in terms of 3 types of help: information, medicine, and counseling or psychotherapy. Now, if they perceived, and we asked them if they perceived that they had received enough of it, if they had received it. Based on their answers, their needs would be classified as in 3 categories. If their needs, if they had received enough of the information, of the help that they needed, their needs were considered to be met for that type of help. If they had not received enough of a certain help based on their needs for that type of help was considered to be partially met. If they had received enough of the help that they needed, that they thought they needed for that type of help, then if they hadn't received any, then their needs can be considered to be unmet. So again, if they had received enough, met, not enough, but received some, partially met, and none at all, according to their needs, unmet. So 3 types of need statuses. Then we carried out a qualitative analysis of the open-ended question: please describe what would help you with your problems or conditions, okay? Now let's move on to some results now that we've gone over how those questions were framed. First, let's go over some descriptive results. From 140 participants, after excluding those that did not complete the mental health care section, those that did not know if they had a mental health problem, or that reported that they did not have one, nor a mental health care need, we excluded those, and we ended up with 82 participants reporting a mental health problem and a perceived need for mental health care. Most of these participants were women. They were 45 years or older. Less than half of the sample had achieved a diploma at the university level, and almost half reported a personal yearly income of $25,000 per year. Most of the sample had been suffering from chronic pain for longer than 5 years. The majority was maintained on opioid therapy, and most of them had obtained a diagnosis for their mental health problem. So keep in mind again that we asked the question about their mental health problems. It could be self-reported or it could be diagnosed, right? So the majority had actually a diagnosis for a mental health problem. Most had low perceived social support scores and elevated psychological distress levels. Now let's go on to the results from the close-ended questions, the measure perceived need for care questionnaire. Now, looking at the type of mental health care help, in this case, information, we could see that for approximately, it's well divided into thirds. 1/3 of the participants that reported a need for information for their mental health problems reported that they had not had enough of it. Approximately a third, that they did not have any of the information that they needed. And approximately a third reported that they got enough of the information that they needed. Well, everything's according to their needs, so perceived information needs. In terms of medication, we could see that most of participants declaring a need for medication thought that they had received enough of the medication that they needed. Around a quarter of these participants did not receive any of the medication that they needed, and the remaining did not receive enough of the medication that they needed. And finally, for the third type of help, which was counseling or psychotherapy, we could see that around 2/3 of participants here did not receive enough of the counseling or psychotherapy that they needed, or none at all of the psychotherapy that they needed. And the remaining third stated that they received enough of the psychotherapy or counseling that they needed for their mental health problems. For the people that declared an unmet or partially met need for mental health care, within that measure, there's also a list of obstacles included that participants can check off of a list. And we ask them, what are the obstacles that you've encountered to receive enough or any other help that you needed, right? For your needs to be met. And based on previous studies, normally that use these obstacles are divided into two categories: features of the healthcare system or obstacles related to their personal circumstances. And most participants, according to this measure and classified as such, declared checked off obstacles that were related to their personal circumstances. And I can read you some of the obstacles that were included in this category, such as not knowing where to get help, not having the time for it, the job interfering, having no confidence in the health system, having no financial means, insurance not covering, and everything was phrased as, you did not have enough of this, you did not have confidence, you did not have financial means. And for the obstacles related to features of the healthcare system, see that around half of respondents declared obstacles within this that would be classified within this category related to features of the healthcare system. Now, when we analyzed the open-ended question instead for suggestions on what could help participants with their problems or conditions, this was outside of the mental health section of the questionnaire. And this was an open-ended question. They could answer as much as they wanted. You see that for most obstacles in the close-ended questionnaire were related to the personal situation. But when we analyzed the suggestions, this was actually reversed. As we see that participants didn't necessarily frame the suggestions as they related to their personal circumstances, but they framed it in a way that they were related to features of the healthcare system, and thus they may need to be solved by the healthcare system itself and not by participants. So most participants that answered this question had comments related to the accessibility of services. Some had comments related to improving patient or health professional education in terms of chronic pain management, wishing their chronic pain condition would be recognized, mainly pertaining to fibromyalgia and others. So I'm going to focus now on comments from the main category within suggestions related to features of the healthcare system, which was the main category that of participants' comments. Within this category of accessibility to health services, we find some main themes, such as access to mental health services, mental health care, comprehensive patient care, service costs. I'm going to read you some comments so you can see as an example of what the suggestions were about. For here, I'm going to read them in English. It's in French, so just to in case you don't read French. So I'm going to read this one. Physical side is treated, but the psychological side of people with chronic pain is not. The chronic aspect of it has an impact on our lives every day until the end of our lives. I think that the need to have to constantly adapt should allow for continuous psychological support paid for by the RAMQ or the government. Now, if we go on to service costs, and we read this comment from a participant, says, financial aid for a psychologist. That's what they would like. In a suggestion, I would like financial aid for a psychologist because $130 for 50 minutes is expensive every week when we don't have any revenue. Before seeing a psychologist, I had asked my family doctor for psychological help, and it had already been 1 year that I was on the waiting list. I was sinking deeper and deeper. So I decided to go to the private sector. Now, another trend that we noticed when we analyzed the qualitative, that open-ended question, was that we could appreciate the fact that since the question was asked in a broad sense and not only pertaining to mental health services, participants took the opportunity to refer to their service needs in a general sense and hinted about the accessibility issues that touches on other services, not only mental health care, given the fact that chronic pain touches on many areas of their lives. And I think that's something also that we saw here in the comprehensive patient care, how that participant wanted help with nutrition, wanted psychotherapy, but also suggestions and counseling for their insomnia caused by chronic pain. But here we see this main theme of accessibility to services. One participant wrote, to have access to the pain team, especially because it is a multidisciplinary team. I've been on the wait list for 2 years, and I know I will still wait many more years. Now, going on to the one of the other themes quickly, we saw that within the education, they touched on education on chronic pain, but also training for health professionals and service information. One participant wrote, concerning pain clinics, I have never succeeded in having information about them, right or wrong. I am under the impression that pain clinics are difficult to access and operate in a closed circuit. Now, I've touched on many subjects, and what I want to conclude my presentation with is both qualitative and quantitative methods allowed us to have a better understanding of the perceived needs for mental health care of chronic pain population and also the obstacles. But qualitative methods helped us to identify new themes that the close-ended question was not able to do, such as continuity of care, comprehensive patient care, education, among others. We were also able to better understand such as the nuances in terms of perceived need for care. Well, we see that the need for care is not only related to one type of service, but it actually touches on many services, and thus their accessibility issues may be related to other types of services as well, and not only one service. And this has to do with the way chronic pain is felt in their lives. Therefore, and of course, another thing is that most participants attribute suggestions and how can things be improved to the healthcare system and not to themselves, is not necessarily accessibility issues that they feel that they might be able to change. Through participants' testimonies, we can appreciate that many also may have financial and other types of vulnerabilities that make it harder for this population to obtain the services that they wish to obtain, together with the fact that they may need to access more than one service continuously, further adds to their burden and inequality issues. I'd like to thank our co-researchers involved in this project, our partners and participants, of course, and some mentions. That's it. Thank you so much for your attention.